Electrophysiology is used to describe the heart's electrical system, the wiring that tells the heart muscle when to contract and in what order. This matters because the heart's a pump, and a pump's useless if its chambers squeeze at random. So there needs to be a signal that starts in one place and spreads through the heart in a very specific sequence, so that the atria contract first, then a beat later, the ventricles contract. That electrical signal doesn't come from the brain, by the way. The heart actually generates its own electricity, a property called autorhythmicity, which is why a heart can keep beating even after every nerve connecting it to the body's been cut. All right, so where does this signal come from? It starts at the sinoatrial node, or SA node, a small cluster of specialized cells sitting in the upper right atrium. The SA node fires off an electrical impulse, and that impulse spreads across both atria like a ripple, causing them to contract and push blood down into the ventricles. That ripple eventually reaches the atrioventricular node, or AV node, sitting right at the junction between the atria and ventricles. And here's an important detail. The AV node doesn't just pass the signal along, it delays it slightly. This delay buys the ventricles a little extra time to finish filling up with blood before they're told to contract. After that delay, the signal moves into the bundle of His, which runs down the wall between the two ventricles, called the interventricular septum. The bundle of His splits into a right and left bundle branch, one for each ventricle, and these branches fan out into a network called the Purkinje fibers, which spread the signal rapidly through the ventricular walls. So the full pathway looks like this: SA node, to AV node with a delay, to bundle of His, to Purkinje fibers. And the whole thing, from the moment the SA node fires to the moment the ventricles finish contracting, takes well under a second. Now here's where it gets interesting. Every one of these structures, the SA node, AV node, and the His Purkinje system, is actually capable of generating its own electrical impulses. They just do it at different speeds. The SA node fires fastest, somewhere around 60 to 100 times a minute, which is why it's normally in charge. See? It's called the dominant pacemaker. The AV node, left on its own, would only fire about 40 to 60 times a minute. And the His Purkinje system, if it had to generate the rhythm by itself, would only manage about 20 to 40 beats a minute. Think of it like a backup generator system. As long as the SA node's working, its signal reaches the AV node and the ventricles before either of them gets a chance to fire on their own. But if the SA node fails, or its signal gets blocked somewhere along the way, the next structure down the line will eventually step in and take over, just at a slower rate. This is actually why some patients with a complete block between the atria and ventricles can still have a pulse, just a very slow one. Their ventricles are being kept alive by their own backup pacemaker cells. Okay, so we know the signal spreads, but what actually is the signal? At the cellular level, it's a wave of voltage change called an action potential, and it happens because of ions moving in and out of heart cells through tiny channels in the cell membrane. In a normal resting heart muscle cell, the inside of the cell sits at around negative 90 millivolts, meaning it's more negative inside than outside. When a signal arrives, sodium channels fly open, sodium rushes in, and the voltage inside the cell shoots up from negative 90 all the way to about positive 50 millivolts, almost instantly. This is phase 0, and it's the depolarization that triggers the cell to contract. After that spike, the cell goes through phases 1 and 2, where calcium flows in and potassium starts to trickle out, more or less balancing each other out, which creates a plateau in the voltage. Think of it like the cell holding its breath for a moment before letting go. Then in phase 3, potassium channels open wide, potassium rushes out, and the voltage crashes back down to that resting negative 90. This is repolarization, and it resets the cell so it's ready to fire again. Phase 4 is just the quiet resting period, sitting and waiting for the next signal to arrive. Now, pacemaker cells, the ones in the SA and AV nodes, work a little differently, and this difference is what makes them special. Instead of sitting still during phase 4 like a normal heart cell, pacemaker cells slowly leak sodium in on their own. which gradually raises the voltage inside the cell, all by itself, with no outside signal required. This slow, spontaneous climb is called the pacemaker potential, and once it climbs high enough to hit a threshold around -40 millivolts, it triggers calcium channels to fly open, not sodium ones, calcium, and that calcium influx creates the action potential in these cells. That's the origin point of every single heartbeat you'll ever have, a self-triggered leak of sodium climbing toward a threshold over and over, automatically. And the speed of that climb is exactly what your nervous system uses to speed up or slow down your heart rate. When you're stressed or exercising, sympathetic signals steepen that climb, so the SA node hits threshold faster and fires more often. When you're resting, parasympathetic signals flatten it out, so the climb takes longer and your heart rate drops. There's one more piece to this puzzle, and it's what keeps your heart from short-circuiting itself. After a cell fires, it goes through something called a refractory period, where it simply cannot fire again, no matter how strong the incoming signal is. This happens because the sodium channels responsible for that rapid phase 0 spike get locked into an inactivated state, and they literally cannot reopen until the cell has fully repolarized back down to its resting voltage. This refractory period is protective. It guarantees that once a wave of contraction sweeps through the heart, it can't double back and re-trigger cells that just fired, which would send the heart into chaos. But sometimes, that protection fails, and this is where arrhythmias come from. If part of the heart has scar tissue, say from a previous heart attack, electrical signals can end up taking a longer, slower path around that scar. And if that detour takes long enough, the original cells at the start of the loop might finish their refractory period and become excitable again, right as the delayed signal loops back around to reach them. Now that signal essentially chases its own tail, called re-entry, and it can spin around a loop indefinitely, competing with the SA node and hijacking the heart's rhythm. This is one of the most common mechanisms behind arrhythmias like atrial fibrillation and certain types of ventricular tachycardia. Blockages can also happen at the AV node itself, called heart block. In a mild version, called first-degree block, every signal from the atria still reaches the ventricles, just with a longer delay than normal. In more severe versions, some signals get dropped entirely, and in the most severe version, complete heart block, no signals from the atria reach the ventricles at all, which is when those backup pacemaker cells in the AV node or the His-Purkinje system have to take over, often at a rate too slow to keep up with the body's demands. All of this electrical activity is actually what shows up on an electrocardiogram, or ECG. The P wave represents the atria depolarizing, the QRS complex represents the ventricles depolarizing, which is a much bigger spike since the ventricles have more muscle mass, and the T wave represents the ventricles repolarizing, resetting for the next beat. When it comes to treatment, the approach really depends on what's actually broken. If the SA node itself is failing, or if there's a severe block somewhere along the conduction pathway, patients may need an artificial pacemaker implanted, which takes over the job of generating a reliable, well-timed signal. If the problem is a re-entry loop, like in certain atrial fibrillation cases, doctors can sometimes perform an ablation, which uses heat or cold to destroy the small patch of tissue responsible for the abnormal circuit, permanently interrupting the loop. And for arrhythmias driven by irritable cells firing too easily, antiarrhythmic medications can be used to prolong that refractory period, making it harder for cells to misfire or for re-entry loops to sustain themselves. In the end, every heartbeat you've ever had traces back to the same starting point, a handful of cells in the SA node quietly leaking sodium, climbing toward a threshold and firing off a signal that ripples through the entire heart in perfect sequence, thousands of times a day without you ever having to think about it.